John Davis Akkara speaking about HFA and OCT in RNFL.
So, good morning everyone. I'll be giving you a quick guide to HFA and glaucoma OCT. Okay, so I'm Dr. John Davis Akkara. What is a visual field? It is an island of vision or a hill of vision, and there is this gap in between for the blind spot. And it has applications in neuro-ophthalmology and glaucoma. Neuro-ophthalmology, we are not going to look at it right now. Glaucoma, you confirm the diagnosis, you follow up for progression, and you check the efficacy of treatment. And this is the instrument design of the HFA. You have this decibels refers to the retinal sensitivity, and apostims refers to the brightness of the stimulus. So they are inversely related to each other. Okay. And stimulus duration is 200 milliseconds. Background illumination exam question 31.5 apostims. And the location is more important to know where the patient is looking at the moment of the stimulus presentation. And monitoring is done by the Heil-Krakow method, where a stimulus is given at the blind spot where the patient is not supposed to be able to see. If the patient sees a stimulus at the blind spot, that is counted as a blind spot visualization. So that is counted as an error. Okay, and there is also a gaze tracker which looks at the pupil position. And the most useful program for established glaucoma is to do a Sita Fast 24-2. You can do a 30-2, but it will just take more time. Patient will get more fatigue. And for an advanced glaucoma, Sita Fast 10-2. And now it has been shown that 10-2 is useful also in a moderate glaucoma. And for a pre-perimetric glaucoma, where you are not sure the patient has glaucoma or not, you can do a full threshold. You can do a fastback. You can do a swap. Okay, blue on yellow swap program also. And so 10-2, it is covering central 10 degrees. It has 68 points. It covers a macula and is useful for advanced glaucoma, also retina and neurological cases. 24-2, central 24 degrees except nasally, which covers 30 degrees, 54 points. 30-2, all around 30 degrees, so it has more points, 76 points. And there is also a 60-4 which covers the periphery. Okay, that is far periphery, 30 degrees to 60 degrees. And you can also check the nasal step. And there are 1.2 million neurons and 3000 neurons annually die, and 20 to 40% neuronal loss is required to produce a field loss, visible field loss. Okay, so it's not a minimal thing, it's 20 to 40%. But in SWAP, 10% neuronal loss can be visualized. Okay, and it starts as a localized field effect, progresses to a diffuse field effect. And I will show you that localized ones are for glaucoma. Generalized can be due to cataract or media opacities or even meiosis. This is how a field looks like. So first section is the patient data section, and then the reliability indices and the patient sensitivity. So this is the raw data and this is the representation. And then there is of course the pattern total deviation here and the pattern deviation here. And then you have the global indices, visual field index and all that, and the glaucoma hemifield test. We'll look at each one in detail now. Patient data, it also measures the pupil size and the demographic data. Refractive correction has to be entered. Date of birth has to be entered correctly because it uses the database for normative data. And the reliability indices, you have to look at fixation losses. This is done by Hale-Krakow method, blind spot monitoring. And also false positive should be less than 15%, false negative should be less than 20%. Very easy to look at it. If it is more, it will put a double X mark next to it. Okay, and yeah, this is just telling you that that is double X mark if it is more. And patient sensitivity is measured in decibels, and so this is the sensitivity. This is the raw data, and after the raw data you get the total deviation here. Total deviation raw data, it is represented here, and this is after subtracting the seventh largest point, and you get the pattern data. So this can be due to anything, cataract or mediopicities or even meiosis, and this gives you localized effects. So whatever is seen in the pattern deviation is what is representative of glaucomatous field effects. And you adjust for sensitivity with age. That is why the entering the age is important. And these are the global indices and mean deviation and pattern standard deviation. We'll not go into the details of that right now. This is the glaucoma hemifield test. This looks at the both the upper and lower sections and looks for any loss of symmetry. If there is a loss of symmetry in these quadrants, then that shows up as a glaucoma hemifield test abnormal. So within normal limits, outside normal limits, borderline, or generalized decrease in sensitivity, abnormally high sensitivity, or low patient reliability. These are all the outputs which can come from the glaucoma hemifield test. And of course, it's for diagnosis of glaucoma Anderson's, you also have to look at the glaucoma hemifield test and the uh, cluster of 3 or more non-edge points in a 30-2, or if it's a 20-2, a 24-2, you can consider the edge points also with a p-value less than 5%, at least one of which is a p-value p less than 1% on two consecutive fields, because fields are not very reliable. You have to check it on at least two consecutive fields. So this is again the same one. A cataract, there is depression in the total deviation but not in the pattern deviation. Cataract, corneal opacity, or meiosis. Okay, and this is a swab test, blue and yellow, and this can detect pre-perimetric glaucoma. If there is even minor changes, up to 10% to 20% neuronal loss can be detected here. And this is one way of looking at the progression. You can also look at, I'll skip these. Yeah, as a progression, you get an overview printout. You can do the glaucoma change probability analysis and change analysis. In change analysis, it gives you these triangles. Open triangles are improving. There are no open triangles here, and the dark triangles are depressed points. So you just, yeah, there is an open triangle here and there is a dark triangle here. All the others are dark triangles. Okay, so that is how you can do the this thing. Yeah, octopus perimetry is another perimetry. Zeiss had the upper hand, so that is not very commonly used octopus, but this is what an octopus perimetry looks like. And it's very similar. This gives a grayscale map, which is not a grayscale, which is a color map in octopus. And here the numbers gives you the sensitivity threshold. The black squares gives you absolute defect. Nothing was seen by the patient in those points. And this is the raw data, and this is the not grayscale, this is a color map. And you get the difference, and that is what is sensitivity loss. Okay, so that is what it looks like, and it gives you the BB's curve so that you can see the defect curve there. So that is what it looks like, and we'll go on to OCT quickly, because visual field has poor repeatability and reliability. OCT, because structural loss precedes the functional loss, but functional loss is what is more important. I'll leave this part. You have to look for the RNFL. So you look at the RNFL, you first see whether the segmentation is correct on the scans here, and then you see whether there is any artifacts here. If there are no artifacts and the segmentation is correct, then you look at the disc area and all that. And if the disc area is not too big, it's a normal sized disc, then you look for RNFL thinning in the various quadrants and clock hours. Due to lack of time, I think I will stop with this. Okay, there's also the ganglion cell complex. So you have to look at the GCC at the macula, which gives you earlier detection, but the more reliable more reliable one is obviously the RNFL. GCL gives you more sensitive tests.